Welcome to the second lecture in this series of 2 on blood flow and the control of blood pressure. We will begin by considering arteriolar resistance. We've had some discussions on this a few times already, and I recall that it is influenced by both the local and the systemic control mechanisms. So we'll consider the local control, sympathetic reflexes, and hormones as they each can affect the arteriolar resistance. And of course there is the reminder that we are summarizing much of the material in this complex topic with this presentation, trying to keep it as brief as possible. And the textbook adds to that, so you really do need to use all resources available to you. So we are considering then the chemicals that can affect arteriolar resistance, or chemicals mediating vasoconstriction and vasodilation at the arterioles, their physiological role, the source, and the type. So we start first with vasoconstriction. We see some of our old friends, norepinephrine, serotonin, and now we see endothelin, vasopressin, and angiotensin II. So the norepinephrine, as you recall, is acting on alpha receptors, and the physiological role is related to the baroreceptor reflex. It's coming from the sympathetic neurons, and it is a neurotransmitter, as you recall, kind of a neuromuscular junction onto the smooth muscles, but using the norepinephrine. And then the serotonin is playing a role in the platelet aggregation, as we talk about in the next lecture series related to blood clotting and smooth muscle contraction. So of course wherever you have a leakage in a blood vessel, you want to contract it and close it off to minimize blood loss. Neurons will be one source, the digestive tract, and platelets will be another source. So the sources and the roles vary tremendously. The textbook mentions drugs that target the 5-HT1 receptors on the vasculature and their association with treating migraine headaches. And this, of course, is a paracrine or a neurotransmitter, depending upon the source type of chemical signal. The endothelin is a paracrine mediator from the vascular endothelium, and it has a effect on the nearby smooth muscle cells in the wall of the vessel, paracrine therefore. Vasopressin increases blood pressure in hemorrhage. We know it also is antidiuretic hormone, so we want to integrate that into retaining as much water as you can at the kidney when we call it antidiuretic hormone. The exact same hormone, here we're calling it vasopressin, because it will cause a vasoconstriction to try to reduce the size of the container. So it's trying to retain as much volume as it can at the kidney and reduce the container size so that you can sustain a normal blood pressure when you are losing blood at some location. So the source is the posterior pituitary, and it is a neurohormone. So it's not only active during hemorrhage. As you know, if you become hypovolemic due to dehydration, then this will be stimulated to be released as well to retain fluid and sustain blood pressure, or really just fluid balance. But anyway, we'll see more of that when we talk about the kidneys. The angiotensin II is involved in increasing blood pressure. So you can see the sources of some of these names originate from the first discovery for their effect on the vasculature. So here's a serum substance that increases the tone of the vessels. Here is another vascular targeting substance that increases the pressure within the vessels. And then here is another angio, the blood vessel, blood-borne molecule that increases the tension within a blood vessel. So in those cases, and obviously the endothelin is talking about some whatever, well, N means a substance from the endothelial cells, right? Okay, so now let's consider the vasodilation. So the epinephrine, the blood-borne hormone of the catecholamines, the ultimate catecholamine, right, will act on beta-2 receptors that are selectively distributed in vasculature trees of the skeletal muscle, the heart, and the liver, and it increases the blood flow there during times when you would be causing vasoconstriction systemically, as in fight or flight, the example used in the textbook. The adrenal medulla is the source. This is, they're calling it a neurohormone, but anyway, we see it as an endocrine hormone, and are reminded that the adrenal medullary cells are modified neurons originating from the neural crest embryologically. Acetylcholine is one of the, in this context, is reminding us of one of the exceptions to the rule that the acetylcholine neurons, or the parasympathetic neurons, do not innervate blood vessels. This is that one exception, one exception that we are considering. I'm not recalling any others at the moment, but I'll be safe and say just an exception rather than the exception. But depending upon your perspective of what's important in life, I guess it may be the exception. The parasympathetic neurons are innervating the vasculature for the erectile tissue, both for the clitoris and the penis, and the female and the male, respectively, and it's acting as a neurotransmitter. So it is the parasympathetic neurons actually innervating the blood vessels directly. Otherwise, you're very safe in saying just sympathetic innervation, as reflected by this first line up here above. But remember, this is under vasodilation, so we're talking about dilation. You have to dilate the vasculature to the erectile tissue to have it become engorged with blood to generate the tumescence, or erection. Nitric oxide is a paracrine mediator. Source is the endothelium, and it has, of course, a paracrine effect. Very interesting discussions on its role in the textbook, because it also plays a role in erection and signaling in that process, and as well for vascular shifts, and as well plays roles in chronically in developing hypertension, even during pregnancy, and I'll refer you to the text for the specifics on that. Bradykinin is another one, and actually it's via the nitric oxide. It increases blood flow, sources from multiple tissues, and it has a paracrine effect. Adenosine is definitely a local metabolite that will increase the blood flow to match the metabolism of the tissue in the area where it's being generated. So if you have highly metabolic tissue, adenosine is one of the molecules that will accumulate as a metabolite, and its source, therefore, is hypoxic cells. They're telling the vessels that they need more oxygen, in essence, and that is a paracrine effect. Same thing, if you reduce oxygen tension and increase CO2 tension, you're going to get an increased hydrogen ion concentration, as well as an increased extracellular potassium concentration. And any one of these, or the full set usually in a normal metabolizing tissue, will increase the blood flow to match the metabolism. So we have a metabolite, and then some of the other consequences of a high metabolic activity of cells to place the call to the local blood vessels to bring them more blood flow and wash away these metabolites. That's how it's reversed. So that's the negative feedback. You bring the flow in that you requested, and then it washes away the signal, and you get the negative feedback. Histamine is another very important vascular vasoactive molecule. It increases blood flow, but also makes the vessels more permeable. So you not only get more blood flow to an area, you have leakier vessels, so you get the exudate of fluid from the vasculature, the plasma, into the local tissue. So you get bit by a mosquito and you get a little red bump. That's part of inflammation. The mast cell is the source of the histamine. You get nasal congestion due to allergies. So the allergens bind to antibodies, IgE molecules, immune system obviously coming ahead, and triggers the degranulation of the mast cells, releasing histamine and heparin. And so you increase the blood flow by volume. The rate slows down, so you don't want it to coagulate. And then you get increased leakiness of the vessels, increased permeability, and you get the localized accumulation of fluid in the vicinity of the mast cells that were activated to undergo degranulation, which is just another term for massive exocytotic event, just like boom, all the granules go out, right? Degranulation. So natriuretic peptides, atrial natriuretic peptide is a primary example. So the atrial myocardium, but it's also produced by the brain, will reduce the blood pressure. It is a hormone and a neurotransmitter. So let's look at it. Natri is sodium, right? Na is natrium. Uretic, so you're going to dump sodium into the urine. Where sodium goes, water goes. So you're going to use this peptide as a hormone acting at the kidney when there's too much volume coming back to the right atrium. So if the right atrium is saying we've got too much volume, hypervolemia, versus a hypovolemia with hemorrhage, with hypervolemia, the ANP is going to be the antagonist of the ADH, antidiuretic hormone, when vasopressin is being thought of as acting at the kidney. And so this is to bring blood pressure from a higher level due to hypervolemia back to normovolemia by dumping sodium and sending the water with it. And of course, at the same time, the ADH or vasopressin levels would decrease so that you would retain less water coordinately. So the VIP, vasointestinal peptide, is a digestive secretion, obviously, and will relax smooth muscle. Its source is from neurons in the digestive tract, and it is acting as a neurotransmitter and a neurohormone. So let's go back and take a look at this here. So if we relax smooth muscles, then we will allow more volume flow at a slower rate, same as histamine, through the digestive tract, and you have more blood there available for the glandular cells to absorb the plasma exudate and then use that to make secretions from the stomach. So that's one way that fluid secretions, glandular secretion, can be increased by relaxing smooth muscle. But it probably also has direct effects on glandular secretions that are endocrine glands of the digestive system. So two ways of thinking of what this digestive secretion might be. So arteriolar resistance is the topic on this slide. And we want to think of myogenic autoregulation. So remember that when smooth muscle cells are stretched from the study of the muscular system, there are stretch activated calcium channels. They open with the stretch. So picture, the blood volume coming to an arteriole suddenly increasing for whatever reason. You stretch the smooth muscle cells, calcium influx will increase. You get the calcium calmodulin activation, and it'll trigger the contractile event as described previously. We'll get into the details here. So the paracrines will respond and cause active hyperemia or reactive hyperemia. And the sympathetic control through the sympathetic nervous system is bringing the norepinephrine, and the adrenal medulla is bringing the epinephrine. So again, for the sake of time in this recording, you're referred to the text to get the exact definitions of these terms and their relationship to the molecules that we had just discussed. Let's move on then to a little bit of a better appreciation of hyperemia as a local event that will mediate the increase in blood flow to meet the metabolic demand of the tissue. So here's a case where we increase the tissue metabolism for whatever reason. The skeletal muscle is a good way to think about it, cardiac muscle, anything that makes them more active, like climb some stairs even. You will increase the release of metabolic vasodilators, as we had listed on the table, into the extracellular fluid, the interstitial fluid nearby, bathing the arterioles. Those vasodilators will bind to receptors or to whatever mechanisms that they use to cause the arteriolar dilation. Relaxation of smooth muscles, one of the major ways you're going to bring it about. And you decrease the resistance, and then that will create an increase in the blood flow. So remember this inverse relationship between resistance and blood flow, and we'll see that formula again. If it doesn't show up on a slide, it certainly is covered nicely as a review in the textbook for this chapter. So the oxygen and the nutrient supply to the tissue increases as long as metabolism is increased. So that is the active hyperemia. Now let's look at the reactive hyperemia. And of course the hyperemia, I'm sure you've figured it out by now without going back to your textbook, is an increase in the amount of blood flowing through an area. So decrease the tissue blood flow due to occlusion, then the metabolic vasodilators will accumulate and the arterioles will then dilate, but the occlusion prevents the blood flow. When you remove the occlusion, so this is not a normal occlusion, this doesn't really happen physiologically, it's outside physiology, if not pathological. Think of a tourniquet. The resistance will decrease, and when resistance decreases, you get an increase in blood flow. And as vasodilators wash away, the arterioles constrict and the blood flow returns to normal. So there is a difference between these two types of hyperemia. One is the local demand, because the cells are at a higher metabolic rate versus basal metabolic rate. Here, if you just occlude blood flow, basal metabolic rate is now going to generate accumulation of the metabolic vasodilators. Right? So normal blood flow would remove them. Well, we have decreased below normal blood flow, so they're going to accumulate, right? So this is like putting a plug in the bathtub, and you did not change the rate at which water is going into the bathtub. So the water is going to accumulate in the bathtub. So that's why it's reactive. It's not because of the a change in the metabolic activity of the tissue. It's a change in the other independent variable, the blood flow. And then when we let it go back, physically open it, then you get this response to it and a tremendous increase in flow initially to rapidly eliminate the accumulated metabolites. So now think of it pathologically. If you get an embolism, remember an embolism originates from someplace else and then passes through the vasculature and lodges in a smaller vessel somewhere, say in the heart. And if it stays there for just a little while and you get the proper treatment in, tissue plasminogen activating factor, as you'll see in the lectures on blood, dissolve that clot before it really causes any damage, and you open up you remove the occlusion, and you get a reactive hyperemia, and that has significant effects on the immediate response of the cardiac muscle tissue that is of clinical importance if you're interested in reading more on that. So reactive hyperemia is important in cardiology for acute MI that is due to a blood clot occluding a vessel, if you can get it open quick enough. So here's the norepinephrine. I'm not going to go through this because this is absolutely a review from the sympathetic nervous system. And of course, it's all dependent on firing rate and concentration and of the norepinephrine at the innervation of the vessel and the actions at the alpha receptor. So there's tonic, and then above baseline and below baseline sympathetic tone. So you have basal sympathetic tone, hypertonic or supra physiological tone, and then very low sympathetic tone. As well, we had previously seen the distribution of blood, kind of in a more general sense, with the first introduction to cardiology. Now we can just quickly go through the relative distributions of blood from the left heart first, and then we'll get back to the right heart. So remember, we tend to focus on the systemic tree, and what's going on there has to be reflected in the pulmonary tree in between the right heart and the left ventricle, as we're indicating here. So cardiac output is 5 liters per minute. Well, you have to have the same amount returning to the right heart. If not, you're getting pooling somewhere in between, and then ultimately another way to look at this is what comes in must go out. So these are very important. If you get the blood accumulating in the lungs, then what's coming in might not equal what's going out. The difference is going to be in the lungs. That's where it'll be, right? If you get a peripheral accumulation in the venous tree, then there's an imbalance as well. So sometimes those slight modifications to readjust to a new level, like when you exercise, you're going to bring cardiac output up. This will change transiently and then catch up with itself. In pathologies, you can get peripheral accumulation of fluids because the heart isn't doing what it's supposed to do. And the text takes you through a couple of examples, and we'll have to defer to that for the moment. So this cardiac output, as liters per minute, is distributed to these various organ targets of the systemic circulation, one part of which we can consider separately as the coronary circulation. The highest, as we scan down through here, is skeletal muscle, and of course there's a lot of skeletal muscle, so this is the collective skeletal muscle of the whole body. So as you get very close flow rates to smaller organs or organ systems, then the amount of flow to the individual organ on a per gram basis, in this case 100 grams, will be a little different. So let's compare the brain, 55 ml per 100 gram per minute, to the skeletal muscle, 5 ml per 100 gram per minute. So even though the total volume flowing in an interval of time to the skeletal muscle collectively, not just one muscle, it's the whole muscular system, is the highest. It has one of the lowest per mass, unit mass, right? So one of the lowest flows per unit mass, and the unit we're looking at here is 100 grams, right? So what has the highest per unit mass flow? 55, 70, 100, well, the kidney. Yeah, so I guess that makes sense, right? The kidneys are going to filter the blood, so they're going to have the highest. What you'll come to discover as you continue into professional studies of physiology, clinical physiology, that this blood flow to the kidney is one of the first to be shut down in stressful times, or if there's vascular shock and things like that. And so in cases of hemorrhage, the kidney becomes at risk very quickly for just a complete shutdown of blood flow to it, and risking hypoxia and ischemia and stuff like that, and renal failure. So you'll hear that a lot of times. One of the first things, if there's a severe hemorrhage, is how are the kidneys, and to give them attention and get some blood flow back to them as quickly as possible, and then everything else kind of takes care of itself. So the contribution as percentage of that total cardiac output and the venous return is the highest, again, collectively from skeletal muscle, kidneys, look at that, livers first, sorry. Liver, skeletal muscle, kidney, the brain, and then on through. So this is the way to look at this kind of information and dissect it and think of the relevance of it. Look at this 0.25 total flow, bulk, or just total flow rate to the skin, and the skin is the largest organ system of the whole body. And how important is that? So this is very regulated, highly regulated, and can go up and down, and it's a pretty decent amount on a per unit mass basis as well. So the total amount to all of the skin is about the same as the total amount to the heart, which is much smaller. So look at the 70 ml per unit mass per minute versus the 10 ml to the skin. So there's more than 7 times the amount of skin mass-wise on our body than there is of the heart, and the heart gets 7 times more blood flow per unit mass. So it's very metabolically active, right? But this can change. You get in a hot situation where you got to get the peripheral vasodilation going to thermoregulate and dissipate heat, and the skin is going to take some blood away from somewhere. Somebody else has got to close down a little bit to let you do that, and a lot of times it'll be to the kidney, because you don't want to make urine when you are perspiring. So you see how it all comes together. That's a very important feature of circulating the fluid within the body. The fluid balance is really important. And so the flow regulation is important. So remember, we have 2 things. We have the velocity and the volume flow. When we see blood flow, we're thinking volume. Note the units, liters per minute, liters per minute. So here what we're seeing is the effect of parallel resistance impacting flow. And if they are in parallel rather than a series of resistors, if you've taken studied electronics at all, or electricity, it's basically the same phenomena. Here we're just looking at fluid flow dynamics rather than current flow, but basically resistance contributes the same. So the 4 liters per minute is distributed equally through A, B, C, and D, each equally 1 adding up to the 4. If you constrict selectively one of them, this redistributes so that the volume that comes in must equal the volume that goes out. Otherwise, it has to collect somewhere. If over any unit period of time, and if this is faulty, then you generate a higher pressure on this side. So that's becomes very important. And of course, a higher pressure on the input side is required to overcome. So if you clamp down on all 4 of these, in order to have the flow in equal the flow out, you've got to have a much higher pressure gradient. And this is how hypertension can develop if you get atherosclerosis of these vessels where they cannot react and they are narrowed. The lumen is narrowed. So to whatever degree you alter the resistance by decreasing the diameter of B, you get the, you could calculate this if you had all the information. You would, and you probably could go through it all to find out what proportional drop in the diameter occurred to generate this change, but we're not into that at this point. We're just saying that if we reduce the diameter of this, we increase the resistance, and the flow is going to decrease. So the others have to compensate to allow for the flow. The precapillary sphincters are the topic of this slide. So obviously you're asking, well, how do these adapt to compensate? And that, of course, sends you to the textbook to look at it. If they are going to increase, then something caused their diameter to increase. And so if they are not actively constricted, they are passively, through the myogenic reflex, passively and locally relaxed. You'll create a little more pressure to drive it, and it'll stretch these, and then they will, transiently there'll be a greater pressure when this decreases, and then when it bounces out and reaches homeostasis again, these will have relaxed to a slightly larger diameter. Or the blood will have to flow faster, higher rate or velocity, to get the same volume through in the period of time. So either of the two ways, you get the volume in equaling the volume out. So the precapillary sphincters are a topic on this slide. So we saw these in an illustration in the first presentation. Their strategic location just before the capillaries branch, either directly from the arterioles or a met arteriole. And we talked about how they could be clamped down, or the tone on those could be increased to shunt past the capillary bed. Now what we're thinking about is localized regulation of these with metabolites to cause them to relax to get more blood flow through the capillary beds. So you have the sympathetic nervous system that can clamp down on these, and it's usually the sympathetic system that's going to regulate the contraction of these. And then the local metabolites will cause the relaxation. So there's constant gas pedal and brake going on all the time. So never think of these as always being just gas pedal and no brake, and then all brake and no gas pedal. There's always each of the gas pedal and brake being contributed at any one point in time. So there is a sympathetic tone, a basal sympathetic tone on these. That keeps its machinery running. Remember, those receptors are metabotropic, not ionotropic. And the local cells are always metabolizing, basal metabolic rate at least, and typically they'll just increase their metabolism. You don't find them decreasing, below basal metabolic rate. So there's a constant bathing of these by the local metabolites as well. So what we need to think about now is how do we get those metabolites out of the local interstitial fluid into the capillaries to wash them away, and how do we get the good stuff in, the oxygen and the glucose and other nutrients and stuff like that. So we want to bring in the good stuff and get rid of the bad stuff, so we think about the exchange. And one way that we accomplish this is that we have a net bulk flow of fluid, the plasma, out of the arteriolar capillary side and into the venule capillary side of a capillary bed. Is that volume equal, or is a little bit left out there, and there's another system, of course, the lymphatic system, to take care of it? So let's consider this. The plasma and the cells exchange materials across the thin capillary wall, so we're aware of this. Of course, gases simply diffuse, and concentration gradient is important, but we're going to see some other gradients as well. The capillary density of any particular tissue is related to the metabolic activity of the cells. Can any of you think of another committed function of local clusters of cells that affects the capillary density? Endocrine cells. Endocrine tissues have a very high capillary density. They're highly vascularized, very rich in capillary beds. And as well, the cells are actively producing and secreting hormones and sensing the blood, so they have a relatively higher metabolic rate. So it is associated with this idea of metabolic activity as well. So remember, we talked about angiogenesis in the first lecture on this. So the cells can contribute to. So if you make your skeletal muscles more metabolically active through exercise, signaling occurs to bring about the increased capillary density. So capillary density is not necessarily static. For endocrine cells, it pretty much is. It's always going to be a pretty high capillary density, but for skeletal muscle and cardiac muscle, it changes with the state of how fit you are. But it's still related to metabolic demands and the efficiency that is an endpoint of the vascularization function, angiogenesis. Capillaries have the thinnest walls, the single layer of flattened endothelial cells, so we've seen and heard of these before, and they're supported by a basal lamina. So every cell is stuck to the connective tissue surrounding it by secreting some proteins that it makes itself, especially an epithelial cell. And this is epithelial, but on the inside, a blood vessel, so it's endo. So it has a basal lamina. So that keeps it attached to the rest of the wall of the blood vessel. The bone marrow, liver, and spleen do not have typical capillaries but sinusoids. So there's an anatomy of the vasculature that we need to consider, and we're not going to get into all of the details because this is physiology. So you need to look in an anatomy book or take an anatomy course to get to the level of anatomical detail required. We're just going to talk about two types of capillaries. First is shown on this slide, and you can see it looks continuous, right? So it is a continuous capillary, and they have leaky junctions. And they're showing these leaky junctions here. And then also you see the basement membrane on the outside of the endothelial cells. So this is a capillary, so you just have the one layer, basically. It's just the endothelial cell layer, and then the thin layer of connective tissue around the outside of it. This gives you the thinnest layer of barrier between the plasma component of the extracellular fluid and the interstitial fluid component of the extracellular fluid. So that's the barrier for the exchange. So we are seeing that there's these transcytosis vesicles that are also called caveolae. You see how this looks like a little chalice type of a thing, a little cave on the edge, and then they become a caveosome, and then they're transported to the other side and become a caveolae on the other side, a little cave opening to let the stuff come out. In some places these become rather large and are even considered as vesicles because they're such big caves, and they can be generated on both sides toward the lumen, the AD luminal, and the side away from the lumen, the AB luminal. So the yellow is the lumen. This would be the AD luminal, adluminal, and then the AB or abluminal. If you abduct something, you take it away. And then they can join in the middle and actually form these channels. So it depends upon the metabolic demands. So the endothelial cells respond very dynamically to local metabolic demands in the tissue. And we saw that they release hormones or paracrine types of hormones from the table, endothelin. They produce nitric oxide, things like that. So these are actually endocrine cells, if you want to think of it that way, and they're very sophisticated transport cells. And they're dynamically responsive and regionally different. Remember the beta-2 adrenergic receptor, differentially expressed depending upon where the where the blood vessel is, what organ in which you find that blood vessel. So they're not just a passive barrier cell. They are very dynamic, and we need to think of them that way. The two types of capillaries, and of course, as we'll see, very important roles in pathologies, so we need to think of them as dynamic extremely important cells, not just passive filtration devices. So the second type are these fenestrated. In French, fenestra means window. So these little openings. Fenestrated capillaries have large pores. Well, they are large as far as pores are concerned, but the naked eye, they're small. Anyway, you can see the abluminal, the abluminal surface of the endothelial cell. If we take away the basal lamina, and you can see it's actually punctuated with these little openings, these teeny windows, fenestrated pores. And what we're envisioning is that these pores are more like this type of a structure right here, but they actually thin down to this narrow membrane, and then sometimes have a little opening in them where that membrane is continuous. So there's the transcytosis vesicles still, as well as the fenestrated pores, and you get the endothelial cell junction that is not a tight junction. So that's very important to understand how when you get a flow of a volume of blood across this capillary wall, how do you get things moving out and in across the capillary bed appropriately? Well, one thing is you have to slow down the velocity. We saw before, we're going to have the same volume of flow across the capillary bed. So we saw that in that illustration where we had 4 liters per minute coming in, and then 4 ones, and a total of 4 coming out the other side. So even though we have increased the cross-sectional area at the level of the capillary, and then again, this is collectively of the entire capillary bed, but if you were just looking at it within a piece of skeletal muscle, it would be the same thing. If you found arterioles, their total cross-sectional area that you were examining would be lower. The highest would be the capillaries, and then the venules balancing out with the arterioles, as you might know. So where you have the highest total cross-sectional area, you're going to have the lowest rate of flow. So if you sat there and you watched red blood cells go by you at the capillary, they would go past you. Each one would go past you at a slower rate than if you were looking at the arteriole feeding into this capillary tree. Again, picture that illustration we had previously with the 1 arteriole coming in and the 4 capillaries. We know that anatomically that doesn't really get organized that way, but that helps us to envision it. But the total volume of blood that would cross the capillary bed, fed by that arteriole, would equal the volume of flow through that arteriole feeding into it. And same thing on the venous side. But the rate at which any one little piece of the blood passing through an individual capillary would be at the slowest for the whole system, because the collective cross-section area. So remember, it's a closed circulatory system, so it behaves like a complete container. So one capillary is part of a full capillary bed, and it behaves like basically under standard controlled conditions like any other capillary, until you start changing precapillary sphincters and stuff like that, okay? So the capillary exchange then, the exchange between the plasma and the interstitial fluid occurs by paracellular pathway or endothelial transport. The small dissolved solutes and the gases move by diffusion, and then the larger solutes and proteins move by vesicular transport. So in most capillaries, large proteins are transported by that transcytosis process that we saw. So with the capillary exchange, we're thinking of a bulk flow, the mass movement as a result of hydrostatic or osmotic pressure gradients. So remember, osmotic is going to place a call for water to move from high water concentration to lower water concentration or the reverse of that, from a lower solute concentration to a higher solute concentration so that things become more dilute. So this osmotic pressure gradient across the capillary wall is extremely important. The absorption, the fluid movement into the capillaries, so there's a net absorption at the venous end. So something creates a pressure to move the water, and where the water goes, other stuff goes with it, right? So if you create a force to move sodium, active sodium transport, like we talked about for the kidney, the atrial natriuretic peptide, then the water follows the solute. But if you create a draw to move water, then some of the solutes are going to come with it, of course, typically down their concentration gradient as well. So the filtration, the fluid movement out of capillaries, is caused by hydrostatic pressure and the net filtration at the arterial end. So we'll just look at this single formula and illustration. There's a bit more detail in the textbook for the fluid exchange at the capillary and the forces involved. So the hydrostatic pressure and the osmotic pressure will regulate the bulk flow. So this colloidal osmotic pressure, designated as the pi, and there's a pi cap that we're considering here, and colloidal osmotic pressure is also referred to as oncotic pressure, as mentioned in the textbook, oncotic, oncotic pressure. So the net pressure, pushing fluids and things that go with it one direction or the other, equals the hydrostatic pressure minus the colloidal osmotic pressure. And so the pressures that are considered with this formula are from within the capillary. So the capillary hydrostatic pressure, shown by the P cap, is higher on the arteriolar side of the capillary bed than it is on the venule side. You don't get flow if you don't have a pressure gradient, right? So the pressure gradient across a capillary bed is 32 minus 15, right? So it's 27. No. 17. Did you get that correct before me, right? But the colloidal osmotic pressure will be constant, a minus 25 and a minus 25 across the capillary bed. So your net filtration is going to be reflective of the net pressure, which you see the height of the blue arrows versus the red arrows. On the arteriolar side, you're going to be pushing stuff out, so your net filtration is highest closest to the arteriole and tapers toward the center, to where you have both of these values are going to approximate each other. And then they're going to change direction to have more of a net filtration pressure toward the capillary lumen, and so you obviously push out good things on the way in and pick up bad things on the way out. Does that make sense? And you can calculate these if you're given values for the hydrostatic and colloidal osmotic, or the net pressure in this, and you have to solve for that. So keep those types of algebraic formulations in mind. So a high hydrostatic pressure within the capillary forces fluid out of the capillary when that exceeds the colloidal osmotic pressure. So therefore the protein concentrations and it's mostly the protein concentrations in the capillary that are higher than the interstitial fluid, and that creates this negative 25 drawing fluid into the vasculature unless the hydrostatic pressure within the capillary is exceeding that value, right? So the difference of these two is 7, right? So we have a net of 7 there. And the other point to make on this is there's 7,200 liters per day will pass through the capillary beds, and the net flow out is about 3 liters a day, which is equivalent over a period of a day of the total volume of plasma, right? Because the blood cells don't squeeze out of here, right? And the proteins from the plasma don't get through here either. So basically, the fluid portion of the plasma is exchanged across the capillary bed in a single day. But what we need to ask is essentially the collective heights of these arrows. Are they equal to this? No, there's a little bit of net flow out that doesn't get back into the capillary bed, and of course that's picked up by the lymphatic system. So there's a lot of dynamics to this, and you know, if you want to learn more about it, this is a really cool simulation in the interactive physiology. So the lymphatic system is there to pick up the difference. There's also a little bit of protein that leaks out, and there's other proteins that might get into the tissue fluid, and of course the leukocytes can pass through. The monocytes, well, we didn't see, I recorded the blood lecture before I did this one in this semester, but you'll see that there's some of the leukocytes can pass through as well. They can get out from the capillary into the tissues, and then they might enter into the lymphatic fluid to get to a lymph node to do what they need to do for the immunity, and we'll see more and more of that as we proceed. But right now we're thinking of the lymphatic system for fluid balance, tissue fluid balance. So the fluid in at a capillary bed is not exactly the same as the fluid out on the venule side of the capillary bed, and the difference, the residuum, is picked up by the lymphatic system, and it is purely bulk flow at low interstitial fluid pressures that cause this. And as you know, as you move and you sit down and you place your arm on the armrest in your chair, you compress the tissue, you massage someone, and you can increase the interstitial fluid pressure, and the only place that the interstitial fluid can go is into the lymphatic capillaries there, and that's what we'll see. So under resting conditions, when there's no external pressures, it's a low pressure interstitial fluid driven bulk flow that is just the hydrostatic pressure, not an oncotic pressure. So the returning fluid and the proteins to the circulatory system occurs here, and it's based upon little flaps between the endothelial cells lining the lymphatic vessels, capillaries. And if they don't show it in here, you need to look in an anatomy book to appreciate that. So it's the anatomy of the endothelial cells lining the lymphatic system that restrict this movement only to hydrostatic pressure, and there is no oncotic pressure that's really participating with this flow. So we pick up fat absorbed and transferring to the circulatory system. That's especially important, as you know, in the gastrointestinal system for the absorption of digested fats, and the serving as a filter for pathogens, so they interplay with the immune system. So here you see that. So the net filtration out at the arteriolar side of the capillary bed does not exactly equal the in on the net absorption side, and the difference, the residuum, generates a slight interstitial hydrostatic pressure that is greater than that typically within the lymph vessels, and there's little flaps between, they're showing these little spaces there between the endothelial cells, and the flap just opens up and lets the stuff flow in. And then if you did something to push and increase the pressure inside the lymph vessel, those flaps just close shut so the lymph does not go back into the interstitial fluid. And then these are showing the parenchymal cells with their surrounding connective tissue in this area here. So this is the anatomy of the lymphatic system shown on this slide. I'm not going to take a lot of time to describe all of it. You should recognize this, but there are blind end lymph capillaries in all the tissues that remove the fluid and filter the proteins. Well, not all the tissues. Remember the extracellular fluid compartments in the eye and in the central nervous system. And then there's also some in the auditory and vestibular structures, the special sensory systems. So, those don't have dedicated lymphatic drainages. They kind of have their own modified means for dealing with this excess interstitial fluid and the proteins and any lipids, and for circulating them and delivering them to sites for reabsorption back into the circulating systemic blood. So the thoracic or lymphatic duct is on the left side, and the right lymph duct drains the right upper extremity, hemithorax, and head and neck, and then all the rest is drained, the entire remainder of the body, the left upper extremity, left head and neck, left hemithorax, and bilaterally from the at the subdiaphragmatic level all the way to the toes. And then along the way, as you know, there are lymph nodes scattered throughout, superficial and deep. The spleen is very important as well as the thymus gland. They have a very rich lymphatic flow, as well as capillary flow. And it's not even capillaries, it's sinusoids, as you might know, in the liver, the spleen as well. So if this flow dynamic is disrupted, then you get accumulation of fluid in the interstitial fluid compartments systemically, everywhere, right? It can be localized. Cases of parasites causes the classical elephantitis of the locations distal to it. If the parasites clog the vessels in here, then you get edema of the lower extremity. You can see, obviously, with mastectomy, radical mastectomies, a removal of the axillary lymph nodes can basically transect the main lymphatic vessels draining the upper extremity. So it's not so uncommon to have edema in the extremity on the side of a radical mastectomy. If it's bilateral, then there's important measures to be taken to deal with it. Sometimes the surgeon can be careful to maintain those. Other times, depending upon the severity of the case, you need to remove all of it, all of the lymphatic tissue within the axilla, and then it becomes a post-surgical treatment challenge to deal with it otherwise. Cases of obesity, where the abdominal adiposity and the adiposity in the lower extremity reach a point where they physically occlude these inguinal vessels. They'll get these gigantic edematous structures on the medial thigh that often are thought to be fat, but it's just little, sometimes gigantic, can be up to 10, 20 pounds each or more. I think I saw one show where there was like 90 pounds altogether that they removed, just surgically cut it off because there was no way to get the fluid out. They just physically removed these big pouches of interstitial fluid. So if the fluid gets out of your circulatory system into there, you feel like you're hypovolemic, right? Because you're not getting the complete return. So you drink more fluid, and then there's more fluid to contribute to the edema. So morbid obesity leads to tremendously complex comorbidities that are extremely challenging to everyone involved. So there's two causes for edema: inadequate drainage and filtration far greater than absorption. So with certain types of heart failure, the textbook considers one, you get an imbalance across the heart, and the fluid has to go somewhere, and anything that increases the interstitial fluid accumulation is generating edema. The distribution of the balance between the filtration and the absorption, so increase in the hydrostatic pressure, decrease in the plasma protein concentration. So these are factors at the capillary, an increase in the interstitial proteins. So these are factors that affect the capillary. So the increase in the hydrostatic pressure in the interstitial fluid can put more fluid into the lymphatic system, but that's not what is being mentioned here. This is thinking about the hydrostatic pressure inside the vasculature, the capillary bed, the systemic circulation capillary bed, not the lymphatic. And then a decrease in the plasma protein concentration so you don't pull fluids back in. That would impact the oncotic pressure, oncotic gradient. And then, of course, if you had more proteins in the interstitial space, then it's going to be a greater oncotic pressure coming out of the vessel, the capillary, rather than in, as we saw in our illustration. So you can completely reverse or negate that as one of the components. So remember, the hydrostatic pressure gradient across the capillary bed pushes it out, and it's mostly oncotic that will pull it back in because the pressure gradient drops off. The pressure value drops on the venous side of the capillary bed. So now let's consider blood pressure control. So the components of the baroreceptor reflex are shown on this slide. So we always have a stimulus, a sensory receptor, an integrating center, efferent pathway, and the effector. So the change in blood pressure is the stimulus. Carotid and aortic baroreceptors are where we find stretch receptors. So remember, we talked about the compliance of the aorta. So when the left ventricle empties into the aorta, it stretches tremendously and then recoils. With that stretch, you get information. You get stretch receptors in the adventitia, and it sends a signal to the brainstem, as we will see. And so this is where we have baroreceptors. Now these are the pressure receptors. And then as the blood pressure is distributed through the first branches, which very quickly gets it to the brain, headed toward the brain, right? You have the carotid baroreceptor that is right at the bifurcation of the common carotid to the internal and the external carotid arteries. So this is a pressure differential signal to the brain about blood flow to itself, is the way you want to think about this. You see in boxing and stuff, somebody gets punched in this area here, and you make the brain think that there's a high pressure here, then it cuts off blood flow, right, and reflexively, and they're knocked out. That's one of the ways that you get knocked out in boxing and karate and stuff. So these are pressure receptors. As you know, the carotid body is here. That's a chemoreceptor. We'll talk about that with the respiratory system. So the sensory neurons, as they are stretched, will fire. So they send a baseline signal with each stretch on these vessels, with each pulsation. They send the tonic baroreceptor information to the medulla, the medullary cardiovascular integrating centers. There's several nuclei that are involved, some that are sympathetic and some that are parasympathetic as far as their targets are concerned. The decisions they make will affect either of those two systems separately or coordinately. So the parasympathetic neurons are going to be affected, as well as the sympathetic neurons. So the anatomical circuits are not being emphasized here. There's a lot going on with anatomical circuitry to get down to the spinal cord to activate sympathetic preganglionic neurons, and in the craniosacral portions for the parasympathetics. So keep that in mind. This is highly illustrative. And the parasympathetics, as you recall, through the vagus, innervate the SA node. And the sympathetic neurons also innervate the SA node and the ventricles. So remember, the sympathetic nervous system can affect contractility as well as heart rate, and the arterioles as well. So this is a very complex coordinated circuit system that is really important, and of course if things are required, you can affect the smooth muscle in the veins and either increase the tone to get more blood back to the heart, and don't let too much blood pool in the venous side. And then we've talked about constriction of arterioles and precapillary sphincters in previous slides, and how to regulate flow into tissues, and selectively as well. Well, now let's think of blood pressure, the baroreceptor reflex, the response to an increased blood pressure, and then to a decreased blood pressure. So we have our key here. I'm not going to take the time to go through that. So we have an increased blood pressure, an increase in the firing of the baroreceptors in the carotid arteries and the aorta. So this is above baseline because we have more stretch with higher pressure with each pulsation, right? And then you have the sensory neurons in the cranial nerves, and then and it's mostly 9 and 10. The glossopharyngeal and the vagus nerves are where these sensory neurons are located. Cardiovascular control center in the medulla oblongata will have impacts on the sympathetic output and the parasympathetic output. So here what we're doing is we're increasing the firing to the cardiovascular medullary center, exciting neurons, and those are going to then excite inhibitory neurons that inhibit the sympathetic nervous system. But at the same time, they're going to excite excitatory neurons that will increase excitation of parasympathetic preganglionic neurons, such as in the dorsal motor nucleus of the vagus, as it's called, of the vagus nerve. Insert in here some of that type of circuitry that we studied even with the first integration chapter on the spinal cord reflexes. So how can you get an increased firing rate here that's excitatory and end up inhibiting the sympathetic nervous system? Well, you just excite a GABAergic neuron that's going to inhibit the drive to the sympathetic nervous preganglionic neurons in the spinal cord. Simple enough, right? And if you step on the brake, you slow down something. And here, you're going to step on the gas pedal. So there's less norepi released. So at the alpha receptor in the arteriolar smooth muscle, you're going to get a decreased event there. Remember the mass action, the law of mass action. So the smooth muscle is going to relax, the tone is going to decrease, you get vasodilation, you decrease peripheral resistance. And with the beta-1 receptor at the ventricular myocardium, you're going to decrease the force of contraction. And the beta-1 receptor at the SA node will contribute, you're taking your foot off the gas pedal at the SA node to slow down heart rate. If you increase parasympathetic output, there's more acetylcholine in the muscarinic receptor in the SA node, which is putting the brake on the heart rate. So you're taking your foot off the gas pedal and you're putting your foot on the brake. And so you can slow down heart rate quite effectively this way. And remember, both the contractility and the heart rate, this is going to affect stroke volume, remember? And the heart rate times the stroke volume. This is an indirect index of stroke volume. If you contract the heart harder, you increase stroke volume. If you contract the heart less hard, right, decrease contractility will decrease stroke volume. So this is a direct indicator of stroke volume. It'll go down some. You bring down the heart rate, and you bring down cardiac output, and you bring blood pressure back toward baseline. And then when blood pressure is in the normal range, the stretch on the sensors is going to be what it should be, and that's the negative feedback that we're back at baseline, so we can settle back into baseline activities and either sustain these if we need to keep the blood pressure low, or we can, it was just a transient episode, like you got startled, right? You get startled and you increase your blood pressure. This kicks in just transiently to bring it back, and then you go back to the normal sympathetic and parasympathetic tone. So it depends upon whether it's a normal physiological stimulus, whether you're going to exercise and stress it a little bit more, or if it's pathological. They're very different states of, a gentle physiological response of getting up and walking across the room versus extensive exercising for hours, like running a marathon, versus pathology like hypertension. With hypertension, that system is trying to fix things, but it can't, so it's in a totally different state than when you're just trying to reverse from running a marathon or versus walking up some stairs, where you had to get your blood pressure up just to accomplish that. So the baroreceptor reflex, so we're thinking of the response to orthostatic hypotension. So now we're going to get a drop in mean arterial pressure just from standing up. And this happens transiently and rapidly whenever we stand up. If the reflexive response is not good enough, whatever might be malfunctioning, you're going to get dizzy, fall over, or just pass out, right? So when this happens, then the baroreceptor reflex neurons, the sensory neurons, are going to fire slower than baseline, telling the integrating center, the medulla, that there's less activity at the stretch receptors. So now we need to get things going to get that stretch at the receptors back into the normal range. So what are we going to do? We're going to take our foot off the brake, decrease parasympathetic output, and we're going to step on the gas pedal. So this is a coordinated response to hypotension to increase sympathetic activity, and then you're challenged with these asterisks to talk about the transmitters and receptors that are responsible at the arterioles and veins to cause vasoconstriction, to increase venous return, and increase peripheral resistance. So you want to increase venous return by constricting the veins, and you increase peripheral resistance. Remember, the mean arterial pressure equals cardiac output times the total peripheral resistance. So we're getting peripheral resistance here. With the veins, we can increase some venous return, and then we increase ventricular contractility, to increase the cardiac output. Remember, this and stroke volume have to go together. But if you're going to increase stroke volume, you want to give the veins a little bit of tension to bring the blood back faster. Right? If you decrease the diameter of the veins or the compliance, they're more rigid, then you're going to get blood flowing through it faster at a little higher pressure to fill the ventricles ultimately, right? So when they contract harder, you got more stroke volume. And then, of course, over here, we're taking our foot off the brake, stepping on the gas pedal to increase the SA nodal firing rate and increase heart rate. So here we've got factors affecting stroke volume and heart rate. We get cardiac output. Here we're getting vasoconstriction for increased peripheral resistance. CO times TPR is our mean arterial pressure, right? And then when this pressure gets back into the normal range so that you've got an appropriate stretch on our aortic arch and the carotid sinus, then we're back into the normal firing range, firing rate range for these sensory neurons in cranial nerve 9 and 10. And they tell the medulla we're back where we're supposed to be, and it will reverse this if it is a normal physiological response, right? If it can't quite get everything to, think of this. This is orthostatic hypotension, so you're going to have a resolution of this within moments, within seconds. This is going to readjust after you've stood up and begin moving. And so these are very dynamic processes, some of them happening over short periods of time. But imagine if you had a hypovolemia, a hemorrhage that's going to decrease blood pressure. So forget the standing thing here. Then all these things are going to be happening, and it's just not going to be able to get things readjusted. So there's other mechanisms in place that tell the system that think of the skeletal muscle, the gamma motor neurons and things like that, to set the gain on this system to say, you can't return to normal right yet. You lost a lot of blood. You don't have enough volume. You've got to keep things all fired up here. Keep your foot on the gas pedal to keep blood pressure up. So again, you referred to the animation. So now let's wind this up, and I know it went long, but I wanted to get it all into one. The cardiovascular disease risk factors, they are not controllable. Sex, age, family history. And then there are the controllable ones, of course, smoking, obesity, sedentary lifestyles, and untreated hypertension. The uncontrollable genetic but modifiable lifestyle are blood lipids, so these, as you know, lead to atherosclerosis, the HDL-C versus the LDL-C. This is the bad cholesterol, this is the good cholesterol. The HDLs get cholesterol from the periphery and bring it back to the liver. The LDLs are taking cholesterol to the peripheral tissues, and if the tissues don't need them, then it accumulates, is the way to think about it. So these are very dynamic processes of delivering cholesterol from the liver to the tissues, or from the tissues to the liver, and the best way to have it is to have tissue cholesterols being sent to the liver rather than vice versa. And it's not just the liver making the cholesterol, it's your dietary cholesterol. Remember, everything is absorbed through the intestine and goes to the liver first, so it's really coming from the liver into the general tissue in the LDLs to send it to the tissues. The liver is thinking that the tissues need it, if you want to put it in that sense. And then diabetes mellitus, which is a metabolic disorder that contributes to development of atherosclerosis. So accelerated atherosclerosis, dyslipidemia, is a common aspect of the metabolic disorder and diabetes mellitus. So let's consider this role of LDL in plaque formation. And actually what we're going to add to this is the oxidation of the LDLs. It's not just the LDLs, it's that there's so many of them and they hang around, they get oxidized, and then they cannot be completely catabolized and eliminated. They cannot be used either. So they accumulate, and if they get into localized tissue areas, they accumulate, and macrophage try to get rid of them, and it just is ineffective. So let's take a look at this slide by slide. We see the endothelial cells, and then the subendothelial elastic connective tissue, and then the smooth muscle cells. So we're thinking of, say, a distributive vessel like the brachial artery in your arm, or it could be vessels like the internal carotid to the brain, or the common carotids and things like that. And certainly if there's more elastic tissue, it would be the elastic vessel, the aorta. Still, it's this subendothelial compartment that is really important, and there's always a little bit of smooth muscle there in any of these, as you saw, all the way to the capillary. But you don't get atherosclerosis in your capillary. Anyway, it's precapillary. The LDL cholesterol it will pass through the endothelial cells, thinking that it is supposed to be getting to all the cells in the tissue. Remember, these are tissue cells of the body, and hey, you guys need cholesterol, I'm bringing it to you. And usually they're saying, no, I've got all I need, I don't need any more. I'm trying to give you cholesterol for the HDL to take back to the liver, and put it into the feces if we don't need it. So there's this recycling of cholesterol until it isn't needed anymore, and the liver helps to get rid of it as bile, right? And so this LDL is getting into the subendothelial layer, and then it becomes oxidized, and the monocytes will pass into that area thinking that there's a local problem, or whatever it may be. We don't really know exactly what's going on. It's under heavy investigation. And these become macrophage, and they think they need to phagocytize this, but they take it up through a scavenger type of system, not the LDL receptor system, and they begin to accumulate it, and they're not really showing it here. The macrophages, they're kind of showing these white areas in them. They take up the lipids, and they can't degrade them, so they become what are called foamy cells. They're just heavily laden with the uptaken lipids, and there's a lot of extracellular lipid as well. And then you see that it begins to bulge into the lumen. This decreases the diameter, causes turbulent flow as well, because it's not a uniform reduction in the diameter. It is just a protrusion into the area, a plaque, right? And you begin to get fibrous scarring, so activation of the connective tissue. You see there's effects on the smooth muscle cells. They begin to get larger and maybe even increase in number, so you can have spasms where these are located. Obviously, you lose compliance. This is the hardening of the artery, especially if you're getting calcifications. If you ever do take a human anatomy course where you dissect human cadavers, you will find vessels where you're moving them and stuff, like the aorta and the renal arteries, and they may just crack when you kind of move them. That's this calcification cracking. Or they may be so calcified that you just feel them and they're like a hard tube. You can't even crack it. So it's phenomenal when you see it. And their plaques will be scattered everywhere. So it is quite amazing how it happens. And the LDL and the plaque formation are in a bad position when it culminates at this point where you get the rupturing of the endothelial cell. So with endothelial cell injury, you get the exposure of the connective tissue here, and the next lecture series you'll study clot formation. So platelets begin to form a clot, and you can go from clotting to coagulation, and then you've got an embolism, then you can a thrombus, right? And then that can become embolic if it breaks off and goes floating off. So not a good situation at all. This is called a vulnerable plaque. It's vulnerable to producing many different types of acute events, which are not good. They usually lead to occlusion of vessels and traumatic events. So next, let's think about hypertension, and of course it's correlated to the hardening of the arteries, because you lose the distensibility, and you have to generate higher pressures to get the flow through these less compliant vessels. So the risk of developing cardiovascular disease doubles with each 20/10 systolic diastolic change in millimeter increase in millimeters of mercury in the blood pressure. So this is called essential hypertension. It's got no clear cause. That's why it's called essential. And we know that there's a hereditary component, which typically is associated with the dyslipidemia, cholesterol and fatty acids. But there are other factors as well, and we don't have a full understanding of it yet. So we start here with 115/75. Remember I told you that's the new normal blood pressure. Anything above that, up to 130, is putting you closer and closer to borderline. Actually, the 120/80 is considered borderline at developing hypertension. And then as you get every 10 millimeters of mercury above that, 20/10, you get a progressive increase in the rate at which the risk increases. So you can see once you get to the 140, that's the point. And again, it's this line that's tangent to the curve. Look at the slope of it here. What happens to it when it gets up here, closer to the 160? That's a very dramatic change in the slope of that line that would be tangent to that curve versus tangent down here. So that's the rate of change across this, to bring some of the calculus in, is dramatic. And these are very high risk pressures above the 155/95. So the hypertension then is associated with some change, some adaptation, some resetting of the carotid and aortic baroreceptors. They tolerate higher pressures as baseline. They don't take steps to, release your foot from the gas pedal and put the brake on a little bit. They keep your foot off the brake pedal and on the gas pedal a little bit more and contribute to the higher pressures. So that's what I was saying, is that status of hypertension is a different pathology. It's not the same normal functioning system. You can't expect it to behave normally to any kind of a challenge either. So there are risk factors for atherosclerosis, as we said, that can be managed. We know it's mostly the cholesterol ratio. The heart muscle will hypertrophy because it's working so hard. You can end up with pulmonary edema, congestive heart failure. I'll refer you to the text for more detailed discussions on those, as we're getting into a big chunk of time here now for this presentation. And then treatments include calcium channel blockers, diuretics, beta-blocking agents, and angiotensin-converting enzyme, or ACE inhibitors. So there are various lines of therapy that can help the heart. The calcium channel blockers pretty much help the heart, as well as the smooth muscle, right? If you don't let that calcium into the smooth muscle, it'll relax a little bit, decrease the vascular tone, so you decrease the in this hitting the smooth muscle, you decrease the total peripheral resistance, you get your volume down here. The beta blocking drugs are working on the strengthening of the heart, so it can match the demands. And then the ACE inhibitor is actually many different things. It helps the heart as well as helping the vasculature. So we could get into what each one of these would exactly be doing, but what we find is that in a pathological condition, they have very different effects that we might not have been able to predict if we thought of the single thing. If we just decrease angiotensin II, we should relax vessels and decrease total peripheral resistance. But it turns out it has other effects in a hypertensive person. And we have to think whether there's a pathological change in what angiotensin can do in a person that has hypertension, or maybe it helps to cause hypertension and things like that. But if you just gave yourself some hypertension IV, some angiotensin II IV, it may not have all those effects that you would see in a pathological condition when you remove it. Right? So what you think you could produce by adding it, you think you would see disappear when you remove it in a pathological case. And they are not exact mirrored changes. And so there's something about the pathological state that is not equivalent to a physiological response to the same molecule. So in summary, we see we have covered all these. I'm not going to take the time to go through this,